Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. I'm joined in our studio by Dana Hawkinson, Doc Hawk. We're back today to talk about all things coronavirus and COVID. Before we get started, a couple of thank yous this morning. First, the community's been great to our healthcare workers, and today is no exception. Olathe Wahlburgers and the Olathe Fire Department in Hy-Vee are teaming up to deliver 1,100 hamburgers to a very excited and hungry health system during different shifts here on our campuses. We're excited to share this moment live. That'll be done at 12:15 today. We invite you to watch and share the stream on Twitter at KU Hospital News. Help us thank these community supporters. Our staff is especially excited as this is also Health System Week, which normally would mean a big cookout, and we're not doing that right now because the Wahlburgers are here, and what a great opportunity that is. So thanks to folks for doing that. We also want to say a big shout out and thank you to the members of the community who continue to send us not only their questions, which are great, and you've got everybody, I know you've sensed that we love having the media questions. We've had a lot of great questions from the community, and we're here to try to help answer those. And today's program, which we're going to get to in just a moment, is no exception to that. But also along with your questions, sometimes we get cards and pictures. That's pretty cool to see some of these. Like this one from Megan, who says, "Squeaks and Honey are all ears when the update begins." Megan is fostering these two fur balls. These pictures made us smile. We thought you might enjoy this too here in the age of COVID. I just hope this doesn't mean our update is going to the dogs. Wow, did I really say that? Hey, I've done some pretty great humor. Remember, I talked about dirty money and money laundering, so I guess I got to talk about this too.
Mark that little.
Yeah, I'm going to mark that day. Either way, Squeaks and Honey, we're here for you in the community as long as there's interest and a need to communicate. So let's get started. Today we are really, really happy to have back several of the chief medical officers from the different hospitals we've been talking to. And if you remember, we spoke a little bit about that in the past, that the CMOs from a number of hospitals have come together for weekly, bi-weekly, 3-time weekly calls where we just exchange ideas and kind of talk with each other about what's going on and share just thoughts and knowledge. And so Dr. Raghu Adiga from Liberty Hospital, Dr. Larry Botts from Adventhlealth, Shawnee Mission, and Dr. Mark Steele from Truman Medical Center and University Health are joining the conversation today to talk about how COVID-19 is affecting their hospital and their lives there. And tomorrow we're joined by Dr. Robert Mosier, who's the Dean of the University of Kansas School of Medicine in Salina, and is a professor not only of medicine but also of preventive health and public health. He'll be joining us along with Senator Jerry Moran. And, of course, it's always great to hear from Senator Moran as he brings the latest news back from Washington, D.C. So first, let's get a hello from our guests on the line. Dr. Adiga, how are things in Liberty today?
Hello, good morning. Thanks for having me on. And Liberty is doing good. Here in the Northland, we've been really blessed, let me tell you. We were very happy to discharge our last COVID patient in the hospital on Friday. And we've been lucky since then. We have not had any inpatients at all in the hospital. We do get about 3 to 4 every day of suspect patients, but we've been able to run the rapid test, and they've all been negative so far. And as you know, in the Northland here, Clay County and Platte County and the Ray County, the counties around us, have had fairly small numbers of cases since the beginning itself. So that way we've been really lucky. Having said that, there have been a couple of small clusters in the senior living facilities around us. And so we remain cautious about that. And we do run a long-term care facility within the campus, North Terre, that has about 90, 92 residents, and we've been lucky so far with them and the staff members in keeping the COVID out. In terms of what we're doing currently and what we're looking at, obviously, like all other area hospitals, we have started to ramp up our operating rooms, diagnostic centers, and all the service lines, including cardiac, spine, and orthopedic. The things that we were not doing as an emergency, we are slowly ramping up, and we are about 60% or so of our pre-COVID numbers, both in the hospital and the clinics. So our goal right now is, number one, being able to provide simultaneous care for COVID and non-COVID patients as efficiently and safely as possible. With that in mind, we are always prepared, and we watch our PPE and ability to expand beds and staffing. And we did a staff drill again last week just to make sure we can handle the surge. And we keep, the safety aspects of universal masking, social distancing, and those kind of things. And the second thing that we are focusing now on, especially with these senior care facilities, our collaboration with the facilities around us. So we've been talking to our Clay County Health Department, Kansas City, Missouri Health Department, and the facilities trying to figure out what kind of assistance do they need for surge planning and efficient patient transfer, those kind of things. And also we have a lot of area businesses and schools and colleges around us, providing them some expertise in terms of planning from a healthcare perspective. And lastly, we are the first major hospital when you come down on I-35 from Iowa border, and there are a lot of patients that we are recognizing that they've been kind of not seeking care. We talked about this last time also, and we witnessed that in the ED too. People who've had, mini strokes and have sat at home with them and then show up with a big time stroke. Just an example, and those kind of things, trying to educate the patients and general public as much as possible that don't sit on it at home when you need to seek care. So those are our areas of focus lately.
Well, it's great to have you back. And Dr. Adiga joins those CMO calls, and he and Doc Cocker are both infectious disease physicians. So some of us get out of line sometimes. They have to reel us back in from all of our crazy ideas.
Yeah, he used to teach me a little bit. So.
All right.
Smart guy.
Awesome. On the other hand, Dr. Larry Botts is a pulmonologist like me, and we know the pulmonologists always get out of control, Larry. And how are things over at Advent Shawnee Mission?
Well, you're right about us getting out of control, but fortunately it's under control here. Thanks, Steve. I really appreciate the opportunity. Our experience is very similar to most of others in the regions. We've seen a steady decline in our hospitalized patients with COVID over the past month, and it really appears that this area of the country, we started shelter in place and social distancing early enough that we were able to avoid the huge surge of cases that have occurred in other places. I think now what we're most interested in is we want everyone to know that it is safe to seek medical care should it be needed. I think we've seen a few examples of people who have delayed medical care because of this issue, and as a result have had some potentially worse outcomes or at least conditions that might be much more difficult to treat because of the delay. So as our ability to test has expanded, we can now more effectively separate those patients that are positive in the hospital from those who do not have COVID. We're now testing all admissions to the hospital. We're testing all patients undergoing surgery and or procedures and all OB patients admitted for delivery. In addition, we've altered some of our physician schedules in order to minimize the number of patients in our waiting rooms so there's not as big a groups. What's really been encouraging, though, is what we've found in our early testing of this fairly large group of asymptomatic patients. We've now tested over 1,000 individuals in the last 2 weeks, and we found only 5 positive patients, indicating that it appears the prevalence in this community may be quite low. I mean, it's obviously a selected group and still a small group, but this certainly would be consistent with what we've seen in our hospitalizations. Although, as we begin to open up society, this certainly may change, but I am cautiously optimistic that we have weathered the storm and look forward to continuing to allow a little bit more opening. I think all of us in healthcare owe a debt of gratitude to our community for how they have responded to all the requests for shelter in place and practice social distancing. I think that's had a lot of a big effect on this. I'd second, Steve, your thanks to the community for the support they've shown for our healthcare workers. It's been outstanding and greatly appreciated. And finally, thank KU for organizing the calls. Those calls over the last few weeks have been very helpful, I think, in sharing information and helping to deal with some of the issues as they've come up over the last few weeks. So thank you.
Well, thank you, Larry, and again, I really appreciate your support. And you and I both have rose-colored glasses, I think, so we're hoping that this lower rate of positivity isn't something that could come back to snag us as society opens up. But I think the good thing about the Midwest is people tend to be a little more well-mannered, and I just think we're going to handle this well. Mark Steele is over at Truman Medical Center, and Mark, I think one of the things Truman and especially and KU to some degree have is we serve some minority populations that have been especially hit hard. I know you all have worked really hard in that area.
Yes, good morning, Steve. Yeah, we definitely have, and I think like the others, we've seen a little lower numbers of cases here. We currently have 5 COVID patients in the hospital. 4 that are in our ICU, and 1 is currently on a ventilator. And we have 13 suspect patients pending testing this morning. We just, over the last 2 days, extubated 2 of our patients who had been on a ventilator in the ICU, which was very exciting for us. One of the patients had been on a ventilator for nearly 3 weeks, and both are doing well now, thankfully. So we're very pleased with that. Some of our sicker patients have received convalescent antibody-rich plasma from people who have recovered from COVID via the Mayo Project that others are participating in, so we'll be interested to see how that project pans out. And we've also just received a small amount of remdesivir that was recently approved for emergency use by the FDA, our first batch. So we'll be interested to see how that works out as well. Today, we've discharged a total of 46 patients from our hospital. As you sort of alluded to, we continue to be out in the community with our mobile testing van, and the response to that has been great. We had more than 90 people with symptoms show up in 1 4-hour testing period at St. James United Methodist Church. Ruskin High School, where we were at, wasn't far behind with 84 tested. We've been busy this week, too. Yesterday, we were at the Jackson County Courthouse in Independence and at Northeast High School in Kansas City. Tomorrow, we're going to be at Blue Springs High School offering testing. And for anyone out there who's interested in being tested, we ask that you call 404-CARE, which is 404-2273 to set up an appointment. As my colleagues have said, we're starting to bring back patients for clinic visits and elective surgeries as well. And we have quite a list of people who've been waiting for surgery or to see their doctor. So we're starting with those who we had to postpone early on in the pandemic. When folks come back, the hospital may look a little different than it did when they last saw us, with everyone wearing masks and socially distanced waiting rooms. But behind our masks, we'll be smiling and happy to see them when they arrive. Like others, we are also performing COVID testing on all of our patients having elective surgeries or high-risk procedures within 48 to 72 hours of the scheduled surgery or procedure. As I mentioned, all of our staff are required to wear masks to protect the patients and their fellow staff members, and the patients are also asked to wear masks to protect the staff and our other patients. And of course, we are all practicing frequent hand washing and cleansing of high-touch surfaces and practicing social distancing. So same message from the others that it's safe to come and see us, and if you have an issue that needs to be addressed, you should come and pay us a visit. So that's what's going on here at Truman.
Mark, thank you. And I think that those clinics that you all have done are that's just great. And you mentioned Jackson County, Missouri, the city of the courthouse, Independence, Missouri. Truman High School, that was my stopping grounds a long time ago, class of a very long time ago. We're not going to say the actual year, Dana. How are we here at KU?
Yeah, I would like to echo the thoughts of our guests. Absolutely. You know, I think we have been very lucky here. We are doing well, and by here I mean the Midwest, the Kansas City area. We have 21 patients in-house. I think, again, we're in that equilibrium now where we expect to be. It would be great if it went down. 21 patients. 9 of those are in the ICU. And I would just like to thank our guest for her acknowledgement and watching and listening. And we'd just like to tell all of our watchers and listeners that we really pride ourselves on getting the right, accurate health information and public health information out to the public. Some of the information that is coming in so quickly is peer-reviewed, some of it is not, but we try to really vet and validate as much as we can to get the right message out to the public. So
yeah, and I would say the best thing about our CMO group is I think we all share that.
Yep.
And I think it's just been a great group of people talking together and trying to just say, hey, here's what's going on, how can we help? So.
Yeah.
Well, let's turn to to media and to our audience and ask what questions you have this morning.
Yes, this is Nate with the health system. I have had somebody ask for several days about what is happening with children. Have we seen any of these pediatric cases similar to what they've seen in New York, with children showing up with symptoms that appear to be similar to those who have Kawasaki disease?
Well, I don't know that we have, Dana, but you answer first, and then let's turn it to our CMO group here.
Yeah, as of a few days ago, discussions with our pediatrics colleagues, we have not seen any of those cases here at the health system. I believe Children's Mercy, from what I heard today, has a case. You know, this reinforces the fact that it's a risk, it's a gamble if you get this disease. You know, we have always been happy and really optimistic and cautious because for the most part, children have been spared from the acute disease. The experience from China really did not report on a lot of children's cases, pediatric cases. We know that is a very small proportion that will go to the hospital and you know, end up dying. Extremely small compared to the older adults. But now we are seeing this sequelae, or this secondary problem, coming from an infection where the child maybe wasn't that ill, but then 2 or 3 weeks down the line have developed this Kawasaki type illness, which is a vasculitis having to deal with your blood vessels.
So it's really inflammation in the blood vessels, and they become narrowed, and they get inflamed. They get narrowed, and then you can actually have some issues around not getting enough blood to vital organs, including the heart, which is, I think, one of the big concerns.
So, yeah, luckily nothing here. You know, we just pray that we continue not to see that. But, again, I don't know if any of our guests have seen that.
Gentlemen, any of you, have you heard or seen any of those cases?
Not here at Liberty. We don't admit pediatric patients. They go to Children's Mercy. But as he mentioned, yes, we've heard about the case at Children's Mercy. That's about the only one that I've heard in Kansas City area.
Yeah, this is Larry Botts at Adventhlealth. I echo that. We have not had any of those cases to date that I know of.
And this is Mark Steele, and I agree with the other two. The only one I've heard of is the one that's at Mercy.
Yeah, I like this low number. That's a good thing.
Yeah.
And best of course, best of luck to the child and the family over at Children's.
Absolutely. And we have to remember, overall, this is an extremely low number of the amount of patients who are infected, the amount compared to the amount of children who are infected. But if it's your child, if it's someone you know, it's just a horrible tragedy. So hopefully they come out of that well.
Another family question. Raz asks, how do blended families manage shared custody safely?
Oh boy, blended families and shared custody. I guess I can say that right. Got any thoughts about that from our CMO team? Dr. Adiga, thoughts? You're the infectious disease. You and Hawkinson, we're going to put you on the spot here.
Yeah, I mean, it's a good question. Unfortunately, you know, the blended families will have to act as, you know, a large family, essentially. It's a large one family, so you're expanding your family unit by 2 separate locations and a different number of people. So you're going to have a collaborative management to make sure that the exposure is limited for the kids who are traveling back and forth. But beyond that, I can't, I mean, obviously, the problems are doubled. That's all I can say.
Dana, what are you thinking?
Yeah, absolutely, the risk is doubled. Just because they are going back and forth, you can control what's in your household. You really can't control what's outside of your household. So maybe good communication with the other parents or other family members, knowing and understanding what their bubble is may help. Continue to do the things we've talked about individually, but you know, that's the best you can do aside from just having nobody go to the other households, I think.
And hopefully each side can agree on good hand washing, don't touch the face, cough into your elbow, trying to maintain the social distance and things of that nature. But there's really, unfortunately, as with so much around COVID, we want to find that magical answer which allows us to somehow control the disease. And the reality is that there is no magic. There's just good infection control and good hand washing, and that's really in all those things. It still comes back to the basics, no matter what else we do. And until we have a vaccination, or until there's lots of supplies of remdesivir,
Yeah.
I think we got 5 to 7 doses of patients or whatever that we were able to treat now. And our combination therapy, there's a lot of some breaking news, I think, around doing combination therapy of different drugs. But man, we're still way early on all of that, and we'll have to see how far that travels. So, other questions?
One thing I would add. One thing I would add is about paying attention to the parties that kids would have at another parent's house, the birthday parties and things like that. I have dealt with that issue when the two different parents are not communicating well, and the one getting really mad that there was a party that their kid attended to that they had no idea, or in a bigger group of friends at the other place. So those are the kind of things to talk about.
Those are challenging. Yep. They are challenging. All right.
So Nate says questions are pouring in for the community. So unless media have some, we're going to go ahead and let him start rocking
Let's
through.
start with the media. Any media questions this morning?
Yes, I'm sorry. It's Cindy from KCTV5. It's actually a two-part question.
Please.
With the 10-10-10 opening tomorrow in Kansas City, do you have thoughts about that? And also, would you dine at a restaurant anytime?
Would I dine? Okay. I'm going to turn to Mark Steele in Jackson County and Truman. All right. So what are you thinking about the 10-10-10 rule before we open that up a little bit more, putting you on the spot? And and where would you dine, Mark?
That's a good question. I think that the 10-10 rule, 10-10-10 rule, except for the final component of the 10, potentially is reasonable. And where would I dine? I certainly would be very cognizant of the numbers of people in an establishment and the social distancing and those kind of things. And then also, quite honestly, I would want to see the employees wearing masks, and clearly I would be wearing a mask to the extent I could, except when I had to eat my food. So those are my initial thoughts.
And that last 10, Dana, says that if you're there for more than, the restaurant has to track you for 10 minutes. And if you've been there for more than 10 minutes, they got to write your name and contact information down, or do something so they can do contact tracing for you.
Yeah. I'd like to preface all of this with, we are trying to give the optimal advice, optimal medical advice, optimal public health advice. But after that, there's the reality of what can happen. So I think in addition to that, we have seen, everybody has seen those diagrams about the contact tracing that have been done on the cases. Is it reasonable also? So when you're going into a restaurant, you're probably going to be there more than 10 minutes. So you're probably going to put your name down, your address, your contact number. Is it also reasonable for the restaurant to put down where you sat? I don't know. I mean, that's going to be hard, but we have always been a proponent of the contact tracing. The contact tracing, along with being able to test the contacts, is going to be important as we move forward. Because even though it's low right now, I think we all agree, the prevalence in the Kansas City area of COVID-19 is pretty low. When you have people opening up and being in public and being around each other, maybe or maybe not adhering to the public health and individual health guidance, we know that will probably spread and the cases will increase. So I think that's another thing to consider as well. I think if you're going to a restaurant, again, if you can look at some place that's more spread out, an outdoor area, I think that certainly reduces your risk. But also the masks, keep it on as long as you can. Washing your hands or using alcohol sanitizer right before you're eating. And if the servers and workers can have their masks on, those are all little things you can do to mitigate the risk as much as possible.
My son's 24 years old, and I'm a little older than that, and just a little. And we would go every Saturday morning to First Watch over in Westport. Love that. That was kind of our thing to do. He's been coming over now, and we're cooking breakfast together, which has also been pretty darn cool, I got to say. And but I think, man, if I want to go back there, I love the food, but I want to go back there, I want to see not many folks in the restaurant. Like I said, everybody having on masks, people washing hands, lots of pure out there, and then I'll probably feel a little safer. I don't know how much different that is. If there's really not many folks around and I can maintain social distance from all angles, I'll feel more like, okay, that's not that different than curbside pickup, and we're doing curbside pickup a couple times a week. So I think it's possible to be safe. it's going to, I think it's hard for restaurants to think, how am I going to keep that kind of atmosphere open? And I know it's different between counties, so it creates a funny playing field. So it's a bit of a challenge. But I think if it's done correctly, it is not as safe as being at home, right? It's not as safe, and everything's a calculated risk. And if you're older or you have other health problems, that risk may be greater than you want to entertain until we see how this goes. Everybody's going to be tempted to run out and do it, but I think if you don't mind sitting back and waiting just a little while to say, is it staying safe? The thing that will make you unsafe is the person who is shedding virus for 5 to 7 days before they're asymptomatic and having a curve start to rise before we know it, because we're not sheltering in place and folks are not following all the infection control measures. There's no way for you to know that, and that's what makes you unsafe. So you just have to decide what's your risk tolerance like, and that's the way I think you can best establish it. So those are my rules for going back out, and I think that we're kind of thinking the same thing. I don't know. Do any of Larry, do you or Raghu, do you guys have any other thoughts there?
No, I think you guys covered it very well. I think outdoor seating and spacing are the two things that I would pay attention. I think the restaurants with larger space are a lot more, safer. But that's the only additional point that I would add.
And Larry, how's this being treated in Johnson County?
Well, I don't think they have a 10-10-10 rule. My understanding is that they do have. They're looking at the social distancing, so making sure that the tables and everybody's seated at least 6 feet apart, which is going to hamper a little bit, especially those restaurants that are fairly small, not being able to have too many people in the restaurant at once. Looking through our rosy-colored glasses, as you say, Steve, I'm optimistic, and I've been looking forward to being able to go out. So I'm probably I would probably be one of those people who will be out there early in all of this. But I think everything that everybody's discussed is absolutely appropriate, and just being now that the weather is going to be nice, hopefully soon, being outside is an advantage, and you get a little more freedom and a little bit more room. So
yeah, I think especially sitting outside, that even helps you with the virus a little more. So
yep.
Any other media questions this morning?
Well, I have questions if nobody else does. So I have had a couple of questions regarding the flu. One person wanted to know what the prevalence was right now because they actually have a family member who tested positive for both influenza A and they were tested positive for influenza A and was COVID negative. And the physician thought it was odd about the flu and didn't even think about testing for the flu initially. And what are your thoughts on testing for both? And then another person was asking that if they had an upper respiratory flu in January and tested negative for influenza A and B, should they consider antibody testing when there's one reliable?
Yeah.
Well, let's first say, Raghu, you're our other infectious disease expert. Dana's here with me, and he's chomping, but I know you're there and probably have some good thoughts.
All right, I'll take the flu question first. As we all know, the prevalence of flu has markedly come down in the last couple of months. When we started all this, we used to test for flu on everybody who presented with similar symptoms of COVID. But as the time went on, we recognized that the number of tests that were coming back positive for flu fell below 1% of all the tests ordered for flu. That was the time we kind of took away that automatic ordering for both tests. And, as Dana would add, there is always a sporadic case of influenza anytime throughout the year that we're going to get. So it can certainly happen, but, the physicians will decide if a particular patient we should be testing for flu, but not everybody with the respiratory symptoms at this time. The second question of antibody I didn't exactly understand the question very well, what they were alluding to. In terms of influenza antibody test is
Dr.
what?
Adiga, I think they were just wanting to know if they should get an antibody test because they were tested for flu and they didn't have the flu. It sounds like they had an upper respiratory infection. I think. I read the question as they wrote it, but then as I was reading it, I realized there was probably
I understand. I understand. That's the question about antibody testing to see if the illness that they had in the past was in fact COVID or not in January. In individual cases right now, Dana will add to my comment. Right now, we are not at a point where we can confidently tell someone that the positive antibody test individually means that they had the infection in fact or whether they have the immunity for it. However, the tests are still useful as an epidemiologic tool for a group of people to, say in the county, you've done a sampling and then you can tell there are so many people with antibodies. So such a percentage of population has had the infection. So I think we'll probably get there, but in individual cases, it's still quite not absolutely certain. Maybe you can say, maybe that was it, but I can't be absolutely certain is going to be the answer.
Dana, if there's increasing evidence that this was here before we knew it, and was probably circulating a little in the community. Thoughts about somebody as early as January?
Yeah, again, it's always good I think it's always good when I have thoughts and opinions that are the same as smart people like Dr. Adiga. So I agree 100% with that. So with the flu, we have to remember that as we were getting into our known cases of COVID, there was still high flu activity. As it went down, it certainly tapered off for influenza. So that's why we were testing for influenza, and if that was positive, we weren't testing for COVID. But that's also because there were published reports in very good journals that the incidence of influenza and COVID infection was very low.
Yeah, and adults. Now that sort of changed with children because it's much more common there.
And as we move forward into the new flu season, because it's either ending flu season or in flu season basically, for the most part, we will probably be testing for both. And I think we will see an increase in co-infection with influenza and COVID. But to second that, then, we don't know how long it was here. So the timeline shifts from when we first thought it was here, from the first case in Washington. Well, now we say, well, maybe it was here January 1. We really don't know the extent of when it started in China either. So we think that probably the event where it jumped species, the virus, was probably November, maybe as early as September, but we still don't know the full extent of that. So there seemed to be one or two different really bad illnesses this year that were maybe classified by people who've had them as being worse than a normal cold or cough. That could just be a variant of our normal common cough and cold viruses. It could be a new cough or cold viruses, something other distinct from COVID. I don't think we'll know that at this point. Certainly, we've heard anecdotes of all of people that we know have had something like this. It would be reasonable to go get tested, especially if you know you haven't had any other illness since that time or nobody in your household has, because then you can reduce the chance that it was actually a new COVID infection that you're having detected with the antibodies. Once an antibody test does get more publicly available and it is validated, and again, I think those things are coming. The science is working there.
The science is better. There's some good reference labs now.
I think it's reasonable to get your antibody test, absolutely, just to kind of look back and see, was it here? And as we get more knowledge about this, we are hopefully going to be able to pinpoint better and more accurately, really when it arrived here. And maybe it was before January 1 that we're saying, but that's still
it's
unknown.
interesting. And Larry, I'm going to ask you to comment on this, but I know in the ICU, historically, we'll see cases of pneumonia that we can't figure out what was it, what was it, and we'll do all these special viral tests and things. And I don't know if there's a higher incidence of that back in January, but I remember a few cases, and now that you look back on it, and you're like, man, I wonder if that was COVID-19.
Yep.
What do you think?
No, I agree with you, and even since we've been more adept and treating, testing those people more routinely, even after it started in March, that we've still had a couple of cases that fit into that category of. We kept coming up. We kept retesting them because they were negative, and kept thinking this is exactly what it looks like. It looks like it's COVID, and I think you're right. There are always been other things out there that have been sort of mysteries. We treat them, as if they were a viral pneumonia, but never really identify what the offending organism is. And I think there were probably some of those cases in January that fit into that category. We couldn't find anything. We weren't testing for COVID at that point, and certainly it may have been prevalent here.
And there was a patient here that we tested, once was tested outside here that was negative. We tested twice here. We kept thinking, my gosh, it feels like COVID. I mean, it walks like a duck, it talks like a duck, it acts like a duck, it's a duck. And then we went out and sent off the antibody testing, and indeed, it was a duck.
Yep. Yeah, absolutely. And, these other...
By the way, because I think I butchered that saying, that meant he was positive for the COVID antibodies. So.
That's right. These other cases, too, that we hear about, they seem, was there a shift in the virus for some reason clinically? Because certainly the cases that I've heard about, the patients didn't go to the hospital. There was one patient who was in the hospital. He was intubated for 3, 4, 5 days. That's certainly different than the COVID patients we're seeing now that seem to be intubated for 10 days, 14, 21 days. So was there another shift? There's thoughts out about there. There's research reports about that. Again, as we get more information, I just think we'll know more, and it's interesting to have those kinds of thoughts and continue to ask those questions.
Yeah. Other questions today? Nate, you're up.
I actually have one regarding daycare centers. What advice would you give to daycares to not have them turn into meatpacking plant situations?
Wow. Okay, daycare to meat packing. Mark, what do you think?
I know.
Please take that.
Yeah, take that one, Mark. How about that? I'm giving you a really good handoff there, guy.
Yeah, that's a hard one, because I think especially young kids, trying to keep them separated, and there's no way you're going to keep masks on them, and so I don't have. I mean, obviously, the bigger the area, the more spread out that they can be, the better. But that's a challenge with kids.
Boy, it is. And Dana, you have some young kids. Can you keep them separated?
Younger. They're younger. They're not daycare, but yeah. I mean, I think that's the issue. I think there's different amounts of roughhouse and horsing around at different ages, but they all tend to be together no matter what age, whether it's 5 to 7-year-olds looking to play baseball, or it's teenage kids out riding their bikes or hanging out. It's all different, but they all have a difficult time physically separating in general. Yeah.
And it's hard to know because Dr. Adiga, I think in the meatpacking plant up in St. Joe, when they started testing the employees, most of them were asymptomatic. But I think over 400 that tested positive.
Yeah, I think somewhere around 430 or 440. Yes, that's a huge number that was positive, and largely asymptomatic.
Yeah, and I think that's the issue at daycare, and then that becomes a way to spread because kids can be vectors, and you don't want to make kids sound like a meatpacking plant, but they can be vectors. So there's really, when you think what's the good way to handle that, I don't know that there is a great way other than maybe a smaller group of people in the daycare, children in the daycare trying to keep hands washed and mask covered and face covered, but that's really hard with young children. So again, like we've said on other issues, this is a question about what your level of risk tolerance is. There's no easy answer, and in fact, there's probably no good answer to the question about is childcare safe? Or daycare safe? Because that's really the question. And for the kids, it probably is safe. I mean, even if there is Kawasaki-like disease in this, it's in an extraordinarily small percentage of children. So it's the daycare is safe to the kids. The question is, who's at home? And if there's an older person or somebody with lots of different kinds of illness or chronic diseases, that's going to be a bigger risk. If everybody in the house is healthy and a little younger, the risk goes down, but there's still risk. And I think that's how we have to look at it, Dana.
Yep, and I would like also to clarify about the meatpacking plant. I was talking to a colleague who is up in St. Joe and asking about hospitalizations. They have a few in the hospital. We do have some of those patients that are Wyandotte County residents as
yeah.
well. So we need to understand that asymptomatic, they were probably asymptomatic at the time of testing because I think they got on the contact tracing
Early.
pretty quickly. More than likely, based on the numerous published reports, those patients, a majority of them will have symptoms. He also thought that there was maybe an issue with being asymptomatic is, just fear of a lot of repercussions when they're saying they're symptomatic. So I think we need to make sure that the public knows that. So either asymptomatic or pre-symptomatic, most of them were probably more pre-symptomatic than going to be fully asymptomatic throughout the 14 days that we usually use
Right,
for
and when
quarantine.
we say, and thinking about it, it may just be a mild cold. Which
Right,
is,
absolutely.
There have been hospitalizations out in southwestern Kansas around the meatpacking industry there, but it's not been overwhelming, and so, which is, I think, good news. Now, we do know that Kansas City was identified as a hot spot. It was in the Star again this morning about some of the things that came out from the federal government earlier in May, and really was just reflecting on the fact there's been a lot more positive cases. I think a lot of it is just more testing, and especially directed testing in places where you would be suspicious, like a meatpacking plant, a prison, and things of that nature. So, Nate, other questions?
I want to make a point, Steve, if you don't mind, about the meatpacking factories. Is the difference between the nursing homes and the prisons, as it compares to the meatpacking factories, is that people go home from meatpacking factories after work. Prisons and nursing homes are fortresses, so it doesn't spread a whole lot to the community. But these places, these people have families, friends, and they go home. And so the secondary cases become important.
Yeah, that's a great point. Thank you. Nate or media or anyone else?
Yep. So I've had several people ask.
Hey, just a second. I heard another question. Was there a
This is
media?
Mark at Truman. I was just going to back to the child care issue, just to also point out, like we did with the restaurants, that obviously to the degree that if their kids are gathering, that they're outside, just like with restaurants, it would be preferable to be in that kind of environment than in a small enclosed space.
That's a great point, because we know the outdoors is more protective. Nate?
So we've had several questions regarding antibody testing now and antibodies. I guess overall, do we know how long antibodies stay in the body after an illness? And then they want to know if we have any antibody tests available in the metro. And somebody else was asking, are the FDA approved, or how accurate are the FDA approved tests?
Dan, I'm going to start with you, and then we'll turn to our panel today.
Okay. Yeah, absolutely. We don't have a lot of data about SARS-CoV-2. What we can tell you from the original SARS, as far as antibody, how long do you keep them in your body, and the MERS, we know that you have pretty high antibody levels for 2 to 3 years out. Is there neutralizing effect there? Is there antibody response there? Probably there's some, but then after that time, your antibodies wane. However, we know that antibodies are created by memory B cells, which are in your body. They're circulating through your body. So if you should happen to come into contact, will you be able to make antibodies to that?
More rapidly the second time around.
Right, to help protect from illness. So again, we know that from those illnesses, you can have antibodies for 2 to 3 years, and then they rapidly decline. For the COVID-19, unfortunately, we don't fully know that answer. We know you're going to have them at least 8 to 12, 20 weeks out probably. If it's anything like SARS-CoV, the original one, you're probably going to have the antibodies for quite some time. And we also have to note that the immune response is also with cellular immunity or T cells. So yeah, hopefully you will continue to have antibodies and have some neutralizing or immunity effect from those antibodies. As we get further and further into this too, some of these labs that have been issued an emergency authorization for these antibody tests are going to be made to submit paperwork to really delve into their sensitivity and specificity. So we should probably be knowing that soon, because I think it was a week or 10 days ago that they got emergency authorization. So we'll know better which labs are more validated, which lab tests are more specific and sensitive for doing the antibody
And
tests.
just to say to our audience, part of the issue is the FDA usually makes these folks go through rigorous testing, but in this pandemic, a lot of those testing requirements were limited. Things were then put out, and so then the testing is kind of done I don't want to say this, but to some degree on the public, and then they have to resubmit the data later to the FDA. Dr. Adiga, any other thoughts around this question about antibody testing and coronavirus?
No, I think Dr. Hawkinson covered it very well. As we get more and more data, I think the tests are getting better. The sensitivity and specificity are getting better, especially with a couple of commercial labs which have a lot of experience in creating these kind of tests. Serology tests in the past for other diseases are getting involved. And they are doing the studies and submitting data to FDA as FDA changed its rules about a week ago or so, demanding that anybody who gets that EUA submit the data. But most of the tests are coming from symptomatic patients. So in terms of using this for asymptomatic people in the community and getting a result out and be able to tell them whether they have the antibody or not, from prior infection and whether they are immune or not, we are quite not there yet. But every week when I look, there is a better study and better results coming. So I do anticipate things will get better.
Yeah, I think so. Today we haven't gone that direction locally. There are some send-offs to the Mayo labs we've done, but we haven't done. But I don't know, Larry or Mark, or any of you all doing antibody testing in-house now?
This is Larry at Adventhlealth. We have not. We're sort of the two infectious disease experts covered it very well, but I think it's just not quite there yet. So we have not utilized that test. We're waiting to make sure that we've got the test that seems to be the best from a specificity and sensitivity standpoint, and then it'll be, I think, just a matter of how long it will be before those are available. And so, at least in a big enough quantity that you can use it in a population. But at this point, no, we've not started that yet.
Yeah, we just got the kit yesterday, and we are validating it. It's the Roche kit, but again, we have to validate and kind of figure out where to use it appropriately.
Let us know. Time for one more question.
All right, this one's kind of, well, I don't think it's a doozy. I have a gentleman who's asking about our social distancing efforts. He says that if COVID-19 runs its course in 14 days and we've been social distancing and semi-quarantining for 2 months, how is the virus still spreading?
Okay. Here we go. All right, another infectious disease question. I'm going to just sit back and listen to our two infectious disease experts talk about that, because it's still out there. It's still moving from one host to another. All it has to do is find somebody who hasn't been infected yet, Dana.
Yeah, I mean, I think it's, it's fairly simple to understand that people are still moving around. There are still people out there. There are workplaces. There are other places of employment. It doesn't take much for one person to get the virus and then maybe spread it when they don't even know they have it, be asymptomatic or pre-symptomatic. Certainly you would hope that if they are having symptoms of illness, they aren't going to work or going to where they need to be. But in that sense, or in that time, we know you can spread it 1 or 2 days before symptoms at least. They can spread it, and then it just spreads. And it to one person at a time. You get to an area, you get to maybe a group of 4 or 5 people that aren't normally in your household, it can spread that way. And so that is the dark nature of the spread of this virus. It is just so efficient in spreading from one person to another.
Dr. Adiga?
Yeah, I agree with Dana. This is a highly transmissible virus. It doesn't take much. So the difference is, yes, we've been doing social distancing. That has helped reduce the number. However, you have to look at the authoritarian regimes and the stricter nature of social distancing that's been practiced elsewhere for comparison. I mean, if you look at the Wuhan area and what they did subsequently to completely stop the spread, they did actually stop the spread for a little while until, of course, you have to give it up at some point, and then, new cases come from outside. So, yes, there is a difference, but obviously that kind of stricter lockdown approach is not practical in many areas of the world, including ours.
Final thoughts from our panel. Mark?
So this is Mark at Truman. Well, I just think that in regards to this issue, that obviously you'd like to think that social distancing is perfect, but obviously it's not, and not everyone is practicing it, which obviously allows for this spread, which is obviously it's highly infectious to occur.
Yeah. Larry, any last thoughts?
I think we've covered it very well. I again just like to thank everybody for all the support that the community has given everybody, all of our healthcare workers over the past 6 weeks or so.
Dr. Adiga.
No, I echo everything that's been said. The community has been superb, and I also want to take the opportunity to thank you, Dr. Stites and KU, for arranging this. This is certainly, I've heard from a lot of different people around here in the Northland too. They listen to this, and it's been very helpful. Thank you.
Thank you. Dana?
Yeah, as we start to open up, because this week it's going to be more, please just continue to listen to us. Take your individual responsibility, protect yourself and your family and others, because we know the virus is out there. And like we talked about, getting the disease is bad. Should you have symptoms, there's always a risk of critical illness and death. Even if you recover, there's always that risk for either you or your child of the subsequent problems, such as the Kawasaki type disease, the inflammatory process, the blood clotting. So just, again, the risk is very real. Protect yourself and others, and do the things that we talked about to continue to have, so that we can continue to have a safe city and a safe area.
Yeah, I'm reminded again that Dr. Seuss is always right. No matter where you go, there you are. So you can travel and do all these things, but it's really about your personal responsibility that helps to mitigate the risk. As we begin to open up society, how we act will define us. It will tell how much risk we have. The virus is still there. We still have patients in the hospital. I'm sure they'd be happy to tell you it's still very real. We still get admissions, and unfortunately, we still see people die. We had a tragic death last night in a young person. This is hard. It's really hard. But don't let it define you. Define coronavirus back. Remember to travel safely. Remember that sheltering at home is still the best. And remember that no matter where you go, there you are. Define the course of this virus by staying safe. We'll see you tomorrow.